thank the ASRS for giving us the opportunity to present some of our work. I'll be talking about pars plana vitrectomy with intravitreal dexamethasone implant for epiretinal membrane management. So when we give the DEX implant, this is during the surgery of ERM removal itself. It's not a separate stage of procedure. So when we are doing the vitrectomy, do the epiretinal membrane removal, we give the intravitreal dexamethasone at the end of the surgery. And I'll go through why we had this hypothesis. And so I do not have any financial disclosures. Yeah, so epiretinal membranes, there can be numerous causes for ERMs. Something wrong, I don't know.
Something.
It's going off again and again. Should we change? Again, it's gone. किसी और लैपटॉप में डालूं?
Dr. Tamir and Dr. Grewal described it should be 1.5 times more than the size of the hole, I think so. And I usually take 1.5 to 2 times because graft shrinkage. That yes, in respect to the size of the hole, what I measured preoperatively, and measuring the disc diameter is the only fixed structure in the fundus. So because while placing the graft over the macular hole, I just insinuate little bit gently into the macular hole so that it can take the contour of the fovea, and later on the graft shrinkage can happen. So compensating all the factors, so it should be 1.5 times at least, or you can take the 2 times also.
So you insinuated
Okay. No, not insinuated. Placing the graft over the macular hole
okay.
and just make a dimple over the
Okay.
macular hole center. Under PFCL, that will be like make the, because they describe 2-stage surgery. I am doing 1-stage surgery. They are keeping the PFCL for 2 weeks. Then again they're doing siliconal PFCL exchange, and later on they are removing the silicon. That means 3 surgery. First surgery with PFCL, second PFCL siliconal exchange, third is removing PFCL siliconal with gas exchange. So I am doing the single surgery followed by silicon removal. That is 2, sir.
So, but what Stano described for these myopics with amniotic, he's doing, he's putting it PFCL and then straight away switching to gas in the next one. That is the other way that they do, I think. Yeah.
I did 7-8 cases. So in one case I placed graft displacement, and I redid the ARG, and that is now hole is closed. I removed the silicone oil after 6 months, and again did the ARG. Just it was in the just above the disc, and I did in the nasal area.
All my macular hole cases, especially long-standing macular hole ones, I use that to slightly circumferentially massage it a little bit. It's like a atraumatic, what you would say, an external indenter. It's in the size of a 25 gauge size. So it's something like that. So just a bulbous tip which is totally smooth, and you gently massage it 360 degrees so that a little bit of elasticity is gained by that usually. Redundancy comes back faster. No, I just go all 360 degrees with that massaging it. Yeah. No, I mean anything except for the ones which you are seeing as stage 1A or 1B where you have a hyaloid sticking in. Those I don't use because they close very easily with the hyaloid. But beyond that, yeah. All right, Raja. Yeah, please.
Sorry about that. So I was mentioning about the hypothesis that idiopathic epiretinal membrane can have an inflammatory component, but more importantly, whenever we peel epiretinal membranes, there are cases where the vision actually is worse than the baseline visual acuity when we started off the surgical planning. There is an increase in the edema on OCT in the first few weeks, and also the visual acuity can drop post-operatively before it starts recovering. And various studies have shown inflammatory cells in peeled epiretinal membranes as well as ILM. So our study was published in the Indian Journal of Ophthalmology a couple of years ago, where we did a comparative study of pars plana vitrectomy with or without intravitreal dexamethasone implant. We enrolled 30 patients in the study. The inclusion criteria were patients with idiopathic ERM, age more than 40 years, visual acuity between 2030 and 2400 with an OCT thickness of more than 300 microns. Patients could be pseudophakic or phakic, but if the cataract was significant, we performed cataract surgery at the same time as the ERM surgery, and the duration of the disease with symptoms should be less than 1 year. So this is the baseline characteristics which were matched between the two groups. If you look at this graph of visual acuity, you can see the control group on the top, and the red line is the study group with the dexamethasone implant. There is a worsening of the visual acuity compared to where you start off with in the control group where we did not give dexamethasone implant, and then gradually the vision improved over 6 months in those eyes where we did not give the dex implant. Whereas in the eyes which received dex implant, by first month itself, the patients had achieved what more or less they were achieving at 6 months. So the recovery of vision is rapid if you were to do an ERM removal along with the dexamethasone implant. So the point is that, as I was mentioning, in ERM removal, sometimes after the surgery, the vision is worse, and it's very embarrassing or difficult to explain to the patient. We set off to at least maintain the vision, but patient is having worsening. And typically for ERMs, the counseling, when we talk to the patient, we say it will take a few months, sometimes even up to 6 months for you to recover or stabilize. So adding dexamethasone implant, we felt that we were trying to improve or shorten the course of recovery for these patients. We will also show the backup anatomically how the OCT also changed in these cases. Again, the gain in vision by more than 15 letters, that is 3 lines, was also more in the study group, although overall the final vision was not too different between the two. Central retinal thickness, again, as you can see here, while there was a reduction in the control group without dex implant, it was a slow process over 6 months, and even at 6 months it was still more edematous than those eyes which received the dex implant. So you see a rapid reduction in the central retinal thickness. By 1 month you are achieving what can be maximally achieved in these eyes, both visual acuity wise as well as OCT thickness wise, whereas if you were not to give a dex implant, it takes 6 months or more for these patients to show improvement. And this is a figure which we published. You can see that in the eyes without dex implant, the edema still persists over many months, 1 month and 6 months compared to the study group. So this is a video of a patient where we gave the dex implant at the end of the surgery. I'll show the technique may not be that simple, or initially you may have challenges how to give the dex implant at the end of the surgery. So a standard 3-port pars plana vitrectomy has been done, and then we are removing the epiretinal membrane. In these cases, I tend to also remove the ILM after staining. After peeling the ERM, I stain the ILM and remove the ILM. Although in that particular study where we published, we did not remove the ILM specifically in those cases. So again, after the ERM removal, we stain the ILM with brilliant blue, peel the ILM in a standard fashion. Because these are epiretinal membranes, you don't have to do an inverted flap or any of those modifications. You just do a standard ILM peeling, and I do a fluid air exchange before injecting the intravitreal OZX implant. So I remove one of the cannulas, and then at the end we inject it, and you can see it nicely resting over the optic disc. This is one patient whom I operated recently, 68-year-old gentleman based in UK, but he's of Indian origin, but came to India, Hyderabad, because there's a long waiting time there for surgeries, especially ERM. He had a thick ERM, vision of 2160. This is the OCT angiography, showing a lot of artifacts, but no significant ischemia, at least in the superficial layer where there's not much of an artifact. And then at 1 month, there is a significant reduction of the edema in this patient with 20/100 vision. So these patients, wherever there is edema, and not just a fine ERM with no edema, I do not tend to inject OZX. But when there is swelling beyond 300 microns along with ERM, in those cases, I do inject these cases. So this is another patient where I did cataract surgery along with epiretinal membrane, and at the end of fluid air exchange, you can see the OZX floating in over there. So in conclusion, the long-term visual outcome and reduction in retinal thickness was similar in both the groups. However, the time taken to achieve the maximum gain, that is the recovery time, was significantly shorter in the Dex implant group. So Dex implant at the end of ERM surgery can hasten the visual recovery. I would like to acknowledge my colleagues Surabhi, Dr. Cooperman and Hasnath, and also thank retina faculty for this. Thank you so much for your kind attention.
Thank you, Raja, for such a nice presentation. I have a question. While injecting this Ozudex injection, I think in last year, ASRS, they have described the path of the Ozudex implant that moves it's a trajectory. The path, it moves like a hyperbola because of the vitreous cushioning effect. That will not hit the. What is the velocity of the intravitreal Ozudex injection in a non-vitrectomized eye? But in a vitrectomized eye, where there is no vitreous cushioning effect, while injecting the Ozudex through the sclera, that will not move through the trajectory. That will directly may hit the opposite side of the retina.
Yes, so that's something I've been storing my video recordings whenever I inject OZX after vitrectomy. Unfortunately, the video kind of went off at the end when I was injecting the first one. The second one was different slightly. So yes, the OZX, it goes in a different trajectory, and then it just settles down flat over the one. So the first time I injected about 3 years ago at the end of vitrectomy, that's when I realized that it has a different trajectory. But what I have started doing is I do a partial fluid air exchange. I don't do a full fluid air exchange. A partial fluid air exchange at the end, between the air and fluid interface, it stops there. It doesn't even go to the retina. So it just floats over there.
Yeah, so I think that's an extremely important point because I also use it a lot post these surgeries, and at the end of a vitrectomized eye, and I normally go into a full air fluid exchange for other surgeries, and here after doing that, if you inject, I've had cases where it goes like a missile and hits the retina, although it didn't traumatize it, but it just looks
so
as
in
if
this
it may hit
video at the end, if you see, this is floating at the air fluid interface, so that's a better way to give a cushion in these patients.
So the other thing is always point the trajectory inferiorly or some not on the posterior pole. And I've also realized that if you press it very gently, it actually goes slowly. It's not that it goes with the same speed. If you press the button very slowly, it will actually come out in a slow manner.
Yeah.
So it's better to do it in these cases like that. Yeah.
Absolutely. Okay, thank you so much.
All right, thank you very much. I think we've run out of time also.
One more thing, you can do complete fluid X and give triamcinolone acetonide at the end of surgery under FG, or you can compare with this triamcinolone with Ozurdex. That is
There
can
have
be
been
another
studies on triamcinolone. Yeah.
Yes.
Okay.
Yes.
Yeah, it just
Yes.
comes out like a snake.
Snake.
Yeah.
Huh.
Yeah, yeah. Yeah, yeah. Because earlier I used to think that it won't make a difference, but then somebody told me that if you press it very gently, it will come out, and it does come
But
out slowly.
but
Yeah.
no, that is the non-vitrectomized eye. Vision is giving the vitreous is giving the resistance. Yes, but in a vitrectomized eye, there is no vitreous.
No, no. So he's talking of the pressure on
Pressure,
the
pressure.
So if you do it slowly, no, it will actually come out like a snake.
Snake.
Yeah.
Yes, yes,
Yeah.
yes.
Yeah. Yeah. Absolutely.
Thank you. So we are ending our symposium.